Supervision Specialty Eye Care is proud to collaborate with the class symposium and present world-renowned orthokeratology expert Dr. Maria Liu as she introduces the 5mm optic zone diameter customization for CRT and CRT dual axis lenses. This evening, we are very fortunate to be joined by Dr. Maria Liu, an associate professor at University of California, Berkeley. She is the founder and chief of the Berkeley Myopia Control Clinic, the first of its kind in a teaching clinic, which now serves as a model for optometry schools across the country. Originally from Beijing, Dr. Liu practiced as an ophthalmologist in China before relocating to the United States in 2000. She obtained her MBA prior to her OD training at Pacific University College of Optometry. She also completed an MPH and PhD at UC Berkeley, and shortly afterwards became a fellow of the American Academy of Optometry. The emphasis of her research is clinical expertise has been on the investigation and utilization of novel contact lens designs in myopia control, which brings us to our topic this evening, introducing the 5mm optic zone diameter customization. Dr. Liu, welcome.
Thank you, Kelly. Good evening, everyone. It's my great pleasure to be part of this webinar, and so that we can share some exciting findings related to the 5mm optic zone diameter study with you. And today's webinar is roughly divided into 3 parts. I will be using the first 35 minutes explaining what we have learned from the study and their clinical implications. And Kelly will explain how to use the recently launched CRT calculators to order both lenses in 5 and 6 optic zone diameter. And we're hoping to leave several minutes for some remaining questions. So since Ortho-K has become one of the primary options, not only for myopia correction, but also for myopia control, how to design and fit lenses to achieve better efficacy in myopia control has been a very hot topic among researchers, clinicians, and the industry players. One of the most popular theories in the subject area is to design a lens with a smaller OZD based on evidence from several retrospective studies. While we're waiting for more solid evidence from more rigorously designed, hopefully randomized clinical trials, a thorough understanding of how the design differences transfer to corneal changes, and again, one step further, its impact on retinal defocus profile is extremely helpful in guiding lens design modifications. So related to this study, we aim to answer the following questions. Number 1, how reliable is the change on the lens design being reflected on the change of the corneal shape? After all, it's the shape of the cornea that matters in the patient's daytime vision for Ortho-K modality, not that of the lens. The second question is, what other factors other than the optic zone diameter play roles in determining the post-Ortho-K corneal shape? And number 3, if there are multiple factors at play together, what are the underlying interacting mechanisms of having these significant interactions? And to help me really address some of these important questions, Paragon's R&D team has worked very hard in multiple iterations in lens designs modifications and a validation process. And so here I'm very grateful for Paragon's R&D, and I'm very excited to be able to share with you some of the key findings from the study. And please also note that this was an independent research project funded with my research grant, so this is not a Paragon sponsored study. Nonetheless, let's get to the details of this, the first part, which is a pilot study. So our general goal is to really understand the performance of CRT lens in a smaller optic zone diameter, but the next immediate logical question to ask is for that 1mm smaller in the optic zone area, where does that extra 1mm go? Do we want to have it all contributing to the landing area, or we want the return zone width and the landing zone area pretty much like share this extra 0.5 millimeter on each side? So here I'm showing you a diagram with a design A, which is a 1.25 millimeter or 125 microns of a return zone width. And the diagram on the right side is showing another version of the 5mm OZD which has all of the extra 0.5 millimeter contributing to the wider landing zone area. So we want to see if those two designs have the same effect on the corneal post-ortho corneal change. So for this pilot study, we have recruited 6 eyes from 3 subjects, and this is a self-controlled crossover design, which I will explain in a little bit why the importance of having this design. Essentially, each subject will be wearing 2 different designs at the same time. This allows a concurrent interocular comparison between the 2 designs. And we fit them and see them back at 1 day, 1 week, and 4 weeks. At the end of the 4 weeks, we perform a complete washout. And during the second phase of the study, they swap the design interocularly. So the one eye wearing a V1 design now wears the other design. So this study has 2 significant advantages. The first advantage is that it allows an interocular comparison at the same time, but it also allows the same eye to have basically a direct comparison between the 2 lenses. And this is especially important for any treatment that shows a significant individual variability, which I can totally show you. There is a huge and a very significant individual variability in any of the ortho-K treatment. So this is basically the results we're getting from this pilot study. And each vertical pair, let me actually make it this way. So you can see there are 3 subjects, 6 eyes results. And on the left side is both eyes wearing the 1 millimeter return zone width. And again, these are both 5 millimeter optic zone diameters with a slightly different width of the return zone. And despite a small difference, you can see there is a consistent trend in which the narrower return zone width, the 100 microns of return zone width, produced a smaller treatment zone area comparing to its counterpart, which has the same optical zone diameter, but a wider return zone width. So even though this is a smaller pilot study, only involving 6 eyes, but from the consistency, we can tell that it's not just the optic zone diameter, but the combination of the optic zone diameter as well as the return zone width that co-determines the corneal treatment size after ortho-K is stabilized. So with that understanding, we have decided to use the design of a 5 millimeter OZ combined with a 1 millimeter return zone width. Again, that means the extra 1 millimeter has a 0.5 millimeter extra in each side, all contributing to the landing zone. So we want to use this design to compare the original 6 millimeter OZ design. And again, we have utilized a self-controlled crossover study. So for this study, and even though it's still a pretty small study, we have 32 eyes of 16 subjects enrolled in the study with a baseline level of myopia of slightly over -3. And here I'm also listing the range of the lens parameters we have used. You can see we have covered a pretty wide range of the base curve and a pretty wide range of the return zone depth in both meridians, and with a maximum delta return zone depth, so a dual axis amount of 125 microns. And we've also utilized a dual axis landing zone design in most of the subjects. And the diameter of the lenses ranged from 10.5 all the way to 12 millimeters. So in this study, each subject wears both pairs of lenses, and we randomize the sequence of the lenses. So at any point, one eye is wearing a 5 millimeter design and the other eye is wearing the 6 millimeter design. And with a 2-week washout period, we reverse the design to allow the same eye with a direct comparison between the 2 designs. And in the interest of time, I'm only including 3 major findings in this webinar. The first finding is that we have found the 5mm OZD design created a slightly but statistically faster onset of a myopia correction. And from some of the sample images I'm showing you here, you can see that for the 5 OZ design, on average, they have created a 0.42 diopter of more myopia correction at day 1 and a 0.31 diopter more at day 7. And this is statistically significant. The difference gradually diminished, and at day 28 or 4 weeks follow-up, we're not seeing the difference anymore. So from each pair, you can kind of see at day 1, these are the topographical changes at the first day or after the first night of lens wear. As you can see, there is a small but consistent change. And more specifically, at the corneal apex, you can see the 5mm lenses is able to create a little bit more dramatic flattening as compared to its 6mm counterpart. Before I share with you the second important finding, I want to illustrate how challenging it is to actually measure the size of the treatment zone on the cornea, as well as the profile of the paracentral steepening. So here you can see, even though we've been talking about treatment area on the cornea pretty commonly, but surprisingly for the whole ortho-K industry, we actually do not have a standardized way of measuring the size of the treatment area after ortho-K. So here I'm showing you the same eye and the topographical changes in two different displays. On the left side, I'm showing you the post-treatment map on the tangential display, and on the right side on an axial display. As you can see, both of them are showing in a custom color scale to maximize the changes. So this is how we measure the size of the treatment zone on an axial map. So we all know that to actually quantify the change or the actual size of the treatment zone, we're using a difference map. So this is the difference map post minus pre-treatment on an axial display. The treatment zone is defined basically between the junctions of where, if we take a look at the bottom right, this is a sagittal profile of the corneal curvature change in the horizontal meridian. And so we're defining the size of the treatment zone between the two junctions where the cornea just started showing flattening. And so on an axial display, you see the size of the treatment zone is a 4.8 millimeters. And for that same eye, if we're changing the display environment and showing a difference map on a tangential display, the treatment size is actually 3.0. So it's a very dramatic difference depending on which display environment you use in analyzing the data. And for this study is less concerning because we're comparing the same subject, same eye, two different designs. So as long as we're using a consistent display for the analysis, it still shows a pretty valid comparison. However, this is concerning if you're comparing the same design with the different studies, and if each study is analyzing the size of the treatment zone using different displays or different algorithm, or we're comparing different ortho-K designs, and we need to be aware of what algorithm each investigator is using in reporting the treatment zone size. Because you can see just between the same eye, between the two display environment, we're seeing almost 2 millimeters of a difference in the size of the treatment zone. And same thing applies to how we quantify the amount of a paracentral steepening and the width of this hot ring or the paracentral steepening. And so if we're using a quantification, we're showing the actual numbers at each concentric location. We can see on the tangential display, the magnitude of a paracentral steepening is very, very different than what we're seeing on the axial map. So currently, there hasn't been any standardized guideline in how to report or how to analyze either the size of the treatment zone or the profile of the paracentral steepening after ortho-K changes. So I urge everybody to be a little bit cautious when we're reading reports on the subject matter. We need to make sure we understand which display or which algorithm we're using in analyzing those data. With that, I want to share with you the second key finding. Basically, the 5mm OZ produced a small but statistically significant reduction in the size of the treatment zone. So I'm showing you all of the eyes included in the study, with this page showing the first half, and this page is showing the second half. So again, I'm not selectively showing you some difference, and instead, I'm showing you all of the eyes participated in the study. So as you can see, even though the difference is pretty subtle, if we're comparing the size of the treatment zone on a tangential display, on average, we're seeing about a 0.2 millimeter smaller of the treatment zone size with the 5mm OZ design comparing to a 6mm OZ control. And similarly, we're seeing a small but statistically significant increase in the paracentral steepening with the 5mm OZ design. Again, this is very subtle, but it has consistency across the board. And the paracentral steepening is more dramatic in the vertical meridian, so 12 and 6 o'clock, more so than the 3 and 9 o'clock. And so this is basically telling us, yes, a 1mm difference in the optic zone design does cause a consistently smaller treatment zone size and slightly more dramatic paracentral steepening, but the difference is much smaller than what was expected from the magnitude of the design difference. So this basically is a quick summary of what we have learned from this study and how this is really providing some insights into the future directions in the research projects. For all of the patients or subjects we have fitted in the study, I did not use any of the diagnostic lenses of the 5mm OZ, and instead we just did a very quick and easy conversion, and which is something Kelly will be sharing after this part. And so for those of you who are used to ordering lenses empirically, or you've already had a diagnostic set with the traditional 6mm OZ, you don't need to, or you do not need to invest in another 5mm OZ diagnostic set. And as we mentioned before, we've seen a smaller treatment zone induced by the new design, but the effect is much smaller than what was expected from the 1mm difference in the design or the optic zone diameter difference on the lenses. And we do see more paracentral steepening with the 5mm lenses, but its long-term impact on the anti-myopia efficacy will need to be confirmed with longer studies with the primary outcome as axial anti-myopia efficacy instead of a short-term study. And for this study, because of our smaller sample size, we only had 5 eyes with a refractive error of over -5. So we don't have sufficient power to really make any claim whether these lenses work faster or work better in higher myopes. We're hoping to have a future studies specifically targeting moderate and higher myopia to test the clinical performance of the 5mm lenses. So for the next 10 minutes, I want to really extend this discussion into the field of myopia control. The main purpose of doing this study is to understand what exactly the design difference on the back surface of the lens has transferred to the corneal surface. So we have heard a lot about this myopia controlled optimized ortho-K design, but is this what we design on the lenses actually what we got on the cornea? And the answer is quite surprising, and the answer is no. So here I have randomly selected 5 pairs or 5 eyes showing you their 6mm or the topographical change with the 6mm design, and on the bottom row showing you their topographical change of the 5mm OZ design. And you can see there are two important points I want to emphasize. Number one, for each vertical pair, that's the same eye wearing two designs with a 1 millimeter difference in the optic zone diameter, or the overall difference we're seeing on the cornea is much, much smaller than what we have included or imposed on the back surface of the lens. And more importantly, across each row, we have the 5 eyes wearing exactly the same design, but getting totally drastically different post-treatment corneal shape. So this is telling us, in general, orthokeratology lacks treatment specificity. What we have imposed on the lens is not what we get on the corneal surface. And this is making it very important to utilize a randomized control study to confirm the anti-myopia efficacy of each design. Because for any retrospective studies, if we randomly selected let's say, the last two types of a topographical change from one design and compared with the first two topographical changes of the other design, we may actually draw the conclusion that the difference we're seeing is actually a design-specific difference, but in reality, they merely reflected the individual variability in the same design. So in the future, I urge everybody to pay more attention to what's actually achieved on the cornea rather than what we have imposed on the back surface of the lens for longer myopia control studies. A related discussion is on how the pupil size is interacting with the post-ortho-K corneal shape and why we're focusing on really pushing for a smaller OZ in the ortho-K treatment and to hopefully achieve a better anti-myopia efficacy. So I want to really explain some of the confusions we've been seeing and basically what exactly is the smaller OZ, where here we're more talking about a smaller treatment zone size on the cornea and how is this interacting with the pupil size. So to really understand how a smaller treatment size on the cornea has impacted on the retinal defocus profile, I'm providing you some really simple schematics illustrating the 3 types of rays actually getting into the eyes. The first type of rays, which is shown here in green, is called the paraxial rays or the central rays. These are the types of rays that's very proximal to the optical or visual axis, and it's in parallel with the visual axis. So it's mostly getting information from the central flattened cornea, and it's projecting to the central retina. Because they're paraxial rays and the paracentral steepening, the area showing in red, has a little impact on the image, retinal image quality, and the pupil size has relatively little impact on the retinal image quality as well. The second type of rays is called the marginal rays or peripheral rays, and which is designated as red here. This is the types of rays that's also the incidence angle is parallel with the optical axis, but it's a little bit further away from the visual axis. And so this types of rays gets a lot of input from the paracentral steepening, and the pupil size plays a huge role in limiting or in allowing how much of the peripheral rays are getting into the visual system. But because the incidence angle is at 0, so it's parallel to the optic axis, it's still mostly affecting the image quality of the central area of the retina. The third type of rays, again, on the right side showing in red, is the oblique rays. These are the rays that's coming into the visual system from an oblique angle. So if we're talking about the impact of the paracentral steepening on the peripheral retina, so the retina projecting to the with some level of eccentricity, this has to be the oblique rays, meaning the light rays coming from an angle. As you can see from the ray tracing or the simplified diagram here, it's the pupil margin on the opposite side, on the contralateral side, that basically delineates how far you can project. So it's not the pupil size from the same side. In other words, pupil size has very little impact on how far away you can project. And for those of us who really want to push for the treatment zone to be smaller and having that paracentral steepening to be inside of the pupillary region, you can see both the angle of projection or the extent of the peripheral defocus has changed a little bit, but not nearly as dramatic as what we expected. So it really goes back to our hypothesis of why Ortho-K is working in myopia control. Currently, there are multiple hypotheses. The first hypothesis is proposing that it is the impact to the central retina, the amount of higher order aberrations, such as spherical aberrations and coma, projected to the central retina that's showing the anti-myopia dosage. And if this theory holds, then really pushing for the paracentral steepening to be inside the pupillary margin makes a huge difference. But if you are a firm believer that it is the peripheral myopic defocus, that's the anti-myopia dosage in Ortho-K, you don't actually need to push too much, too aggressively in pushing this paracentral steepening area to be inside the pupil, because having it shifted inside has pretty limited impact on how far away you can project to the peripheral retina or the extent of this overall projection. So since we haven't fully understand how Ortho-K is working in controlling myopia, simply just using one hypothesis to explain a myopia control optimized design at this stage is probably not very sufficient. And switching topic a little bit, I also want to explain, like when we're evaluating the fitting of Ortho-K lenses, and especially in recent years, there is another hot topic of whether a decentered like Ortho-K fitting actually cause better myopia control efficacy. So before we actually analyze whether a decentered Ortho-K fitting has better efficacy or not, we really want to make sure for the decentered fitting we are seeing, where we think the lenses are decentered is actually not due to the uncorrected angle kappa. As we can see from the diagram here, the angle kappa is basically, or the angle lambda, is basically the angle between the pupillary axis and the line of sight. And so when we're doing corneal topography, if we're asking patients to fixate centrally, the reference point for the first placido ring or for all of the placido rings is actually where the line of sight is passing through cornea. This is different than the geometric center of the cornea, which is denoted as the green X. And the larger the angle kappa, the bigger the misalignment between the red cross versus the green X. And if this is not corrected, as you can see from the very last placido rings and how close it is to the limbus versus on the other side, how big the gap is. And we can get a topographical color map like this, which to most practitioners look like a temporally decentered Ortho-K fitting. But in reality, that's just merely due to the overall projection on the cornea is not actually centered on the geometric center of the cornea. So a quick way of fixing this is to ask patients to nasally fixate on the first or the second ring of the placido or the basically fixation rings, and so that we can actually overlap the geometric center with where the line of sight is passing through the cornea. And after correcting for angle kappa, you can see the same eye had a totally different impression in terms of the centration of the Ortho-K fitting. So here I want to remind everyone, before we start really rushing into understanding whether decentration plays a role in the overall anti-myopia efficacy, we need to first rule out a pseudo decentration due to an uncorrected angle kappa. Lastly, I also want to extend the discussion a little bit about how decentration of the lenses, and in this case, both ortho-K lenses and the multifocal soft lenses, play a role in impacting on the retinal image quality and the retinal defocus profile. So here you can see, because the directions of pupil center or the line of sight is usually the opposite direction as a soft lens decentration, soft lenses are more commonly decentered out and down due to the asymmetric scleral elevation, versus the line of sight is more commonly offset in the superior nasal direction. And if this is a single vision lens, usually it has less impact on the optical quality or the visual quality of the patient. But if this is a multifocal lens, especially a center distance design with a very small center distance region, a large offset will significantly impact on patients' distance vision and also on the retinal image profile. So, and this is something we really need to pay attention to before we rush into a simple conclusion of a certain ortho-K design has a bigger role in anti-myopia efficacy. Lastly, I also want to bring up the topic of a potential synergistic effect between an optical treatment such as overnight ortho-K or a daytime multifocal lenses and its combined use with a low-dose atropine. And currently, from both animal studies and some smaller scale clinical studies, it has shown that if we combine an overnight ortho-K or daytime multifocal with low-dose atropine, it tends to have a stronger effect than the optical treatment by itself. Currently, there are two working hypotheses explaining this synergistic effect. The first hypothesis is basically saying because of the low-dose atropine is still enlarging pupils slightly, and having slightly enlarged pupil actually potentiated the competing defocus created by the optical treatments. And if this hypothesis is true, and we don't actually need to use atropine, anything that can slightly dilate pupil will tend to have a synergistic effect with an optical treatment. And the other hypothesis is saying that both atropine and optical treatments are working independently, but they're both working at a posterior target sites, likely on the retina, RPE, or a choroid, or on the sclera, but through independent pathways. If this hypothesis holds true, then it has to be low-dose atropine instead of any other dilating drops. Currently, we don't really know whether it's the first or the second, or both of them, both of the hypotheses are explaining the apparent synergistic effect between the two. But I just want to bring this to everybody's attention that this is something we as clinician researchers are striving to really understand better. So to conclude, basically, in the future, for any long-term anti-myopia studies, we want to pay closer attention to the actual change on the corneal shape rather than assuming whatever the design change we put on the lenses can be reliably transferred to that on the cornea. And this is especially important for ortho-K studies because what is actually changed on the cornea is actually the anti-myopia dosage rather than the optics of the lens. And currently, we still don't know enough about the exact working mechanisms of ortho-K in myopia control. So the scientific foundation for myopia control optimized ortho-K design is still lacking. And before we evaluate whether ortho-K decentration will have a better or worse anti-myopia efficacy, we need to make sure we're quantifying the directions and the magnitude of the lens decentration accurately and reliably. And lastly, the efficacy and the mechanisms of the combination therapy, combining optical treatment with low-dose atropine, awaits further understanding. With that, I'm going to turn to Dr. Kelly Volz and to explain the newly launched CRT calculator.
Thank you so much, Dr. Liu, for sharing your research findings with us. We're certainly excited to see where this research will go in the future, and how we can further our knowledge base about lens designs and how this translates both theoretically and clinically to our patients. So now, how do we apply what we just learned to our practice and to our patients tomorrow? If you are interested in designing a 5mm optic zone diameter lens, you can visit crtcalculator.com, and you'll see the calculator that is on the right-hand side of your screen right now. These are the same entry parameters if you're used to using our prior calculator requiring the RX sphere, the K values, the VID, and then the optic zone will automatically be set to 6mm, but if you use the drop down, you can go ahead and change it to 5. You now also have the opportunity to customize Jessen factor, and that will show you the results of the lens design recommended. If you are ordering this lens either through consultation or your account manager, just a reminder that you will want to specify that it is a 5mm optic zone diameter lens. If we go to the next slide, we can actually see how the 6mm calculations can slightly differ from the 5mm calculations. So if you look here, we have the same patient with same keratometry values, same RX sphere, same visible iris diameter, but in the right eye, we specified 6mm versus in the left eye, we specified a 5mm OZD. What you'll see as a result is that the RZD values are different. You'll notice consistently that the 5mm RZD values measured in microns will be lower than the RZD values measured in the 6mm lens design. This is on purpose in order to maintain the same fitting relationship that the 6mm OZD Paragon CRT lens has delivered to your patients. So essentially, by making sure that the lens lands consistently on the cornea, like the 6mm OZD design, the RZD has been reduced. So you will notice for all of your 5mm lens orders that the RZD will appear to be lower than the 6mm lens design. However, this is to ensure the same exact fitting relationship. And another common question, especially if you're someone who is used to fitting CRT dual axis lenses, is why would my RZD depth difference, or the difference between RZD1 and RZD2, potentially look different between the 6mm OZD design and the 5mm OZD design? If your 6mm lens design had a spherical LZA result, then the depth difference between the 5 and 6mm OZD will be the same. For example, if you had 100 RZD depth difference in the 6mm lens design, you should still see 100 micron depth difference in the 5mm lens design. However, if you had a dual axis or dual landing zone angle specified in your 6mm lens design, the 5mm lens design is going to be meridian specific, and the calculations for it will be meridian specific as well. So for those lenses that have dual LZAs, you might notice a difference in the RZD difference in the 5mm. Again, this is to deliver that same exact fitting relationship that you've always relied upon in the 6mm lens design, but something to note that you will see slightly different changes between our 5mm and 6mm results for the same patient with the same RX. With that, I want to open it up to further questions, and we do have a couple here. Dr. Liu, our first question for you actually is from the clinical study. How did you troubleshoot the lenses in the clinical study? For example, if a 5mm lens was temporarily decentered, how did you troubleshoot that, and was it different from the 6mm OZD?
So the troubleshooting thinking philosophy is exactly the same as in the 6mm lenses. And I tend to fit CRT lenses on the larger diameters and to really ensure basically a pretty ideal centration from the beginning. So as you can see from the studies, I have used the lenses all the way up to a 12 millimeter diameter. And so if I'm seeing a lateral decentration, whether it's a 5 or 6 OZ, I will still perform most likely increasing the diameter of the lens to improve centration. And same thing applies for superior or inferior decentration. Again, in CRT lenses, superior decentration is more common than inferior decentration, and usually that indicates that we need to increase the RZD too. And so for both 5 and 6 OZ lenses, we increase RZD2 with a 25 micron step.
Great. So we don't have to memorize all new troubleshooting. We can simply apply our knowledge of the ortho-K fitting in the 6 millimeter optic zone diameter size.
Correct. So for some eyes, I can, even though I'm not blinded from the study, by the way, all of the subjects are semi-blinded from the study design. Most of them are optometry students. And if they care to look with their slit lamp, they will notice the drastic difference in terms of the RZDs. And if they really want to unblind themselves in understanding which eye is wearing a test lens versus control lens, they can pretty much tell by the laser markings on the lens. But most of them do not know CRT enough to know that a 5.0 OZ has a shallower RZD. So they are still sort of blinded from the treatment allocation. But for me, even though knowing the difference in the design, I sometimes cannot tell the fluorescing patterns, the difference on the fluorescing patterns. And especially for CRT lenses, we all know that it tends to blend in terms of the clearance in under the return zone.
Fantastic, thank you. Another question that we have is, do you fit based on the topo corrected for angle kappa or based on the topo with fixation directly? So I guess uncorrected for angle kappa. What is your preference?
This is a great question. Since we're teaching clinic and anytime I'm seeing a significant angle kappa, I tend to ask my interns or residents to perform the topography both with central fixation and a nasal fixation so that I have the baseline information for both. And I usually fit just based on whatever I have. And this is only relevant when I see a decentration post ortho-K fitting, and I want to tell whether this is truly a decentration that I need to fix, or this is basically most likely a pseudo-temporal decentration because of the uncorrected angle kappa. So to answer this question, no, you don't need to have an angle kappa corrected baseline topo, but keep in mind that we only have one chance of getting a good baseline topography. So I would urge everybody, if you're not too busy, probably get 2 different sets of topography, one with central fixation, one with nasal fixation, for those with significant angle kappa.
Excellent, thank you. And another question was, it seemed that the lens, the 5 millimeter OZD design, had a faster onset of treatment. Was that true also for patients with corneal toricity? Up to how much corneal toricity do you think the 5 millimeter lens design can correct?
So I haven't seen a significant difference in terms of a 5 versus 6 in working with different amount of corneal toricity. Again, this is something we tend to address better with a dual axis design. So in an RZD difference in the 2 meridians. So far, I haven't had any or sufficient experience in a larger patient population to see if I need to be less aggressive or more aggressive in a 5 OZ design in terms of the amount of a dual axis. And for the purpose of this study, we have like a straightforward calculated the RZD based on what we got from the 6 millimeter lenses.
Excellent. I think probably one of the most asked questions that I see here this evening is, who would you recommend the 5 millimeter customization for? Or maybe what patient would you start in the 6 millimeter versus the 5 millimeter OZD?
This is a great question. I actually want to share beyond the study let me see if I can get back to this slide here. So again, as I mentioned, we don't have enough samples in the study on the higher myopes. So I don't really know whether for higher myopes, the 5mm lenses will work better. But if you can pay closer attention to the top row, which are the same eyes wearing the 6mm OZ, you can see at least for the first three with the larger treatment area, they tend to have a slightly under correction at the corneal apex as compared to the 5mm counterpart. So the number one indication I would use for a 5mm OZ for troubleshooting is those who had a slightly pseudo-central island with a 6mm CRT. I found so far I've had 4 patients that I have successfully troubleshoot that they have pretty ideal centration and a great ocular surface health, but just a tiny little bit of undercorrection due to a slight undercorrection of the corneal center. So I found by switching them into a 5mm lens without washout, they actually created a better flattening in the very center of the cornea. So this has been my number one indication of using the 5mm OZ for troubleshooting, which is minimizing the chance of having that hydraulic pressure not transferred as effectively into the center of the cornea in the larger OZ. And my second indication moving forward, if I'm seeing someone with some level of nisometropia, I will probably do a mini test of fitting the higher myopic eye with a 5 OZ and the lower myopic eye in a 6 OZ to see clinical performance-wise, topographical changes, whether I see a difference. So those would be my top 2 indications of using the 5 OZ.
Excellent, thank you. And for those of you who are wanting to design a 5mm OZD for your lens for your patient, you can utilize the calculator that I recommended at the end of the lecture. However, if you have a patient currently in a 6mm OZD who is doing well that you would like to transfer them into a 5mm OZD, you can do so by contacting a consultation your account manager, and they will calculate what that 6mm lens should be in the 5mm design. Another question that we had was towards the end.
Last comment. I haven't had a lot of experience of actually fitting smaller corneal diameters. And so most of my lenses are either 11 or 11.5. But for those patients who have really truly have like a very small HVID or wide to wide, and you may want to consider starting with a 5mm OZ because you have a wider landing zone area with a 5mm OZ. So the long-term consistency in fitting will likely to be slightly better, especially for those patients that you're thinking about 10.5 or even 10.0 diameter.
Excellent.
Mm-hmm.
And for the summary page, you had mentioned one of your first bullet points was in regards to corneal shape really being the defining attribute of the anti-myopia dosage. Is there a magnitude of paracentral steepening that we should be trying to achieve on the corneal shape? Or what about the corneal shape would you say defines success when trying to have an anti-myopia effect?
This is also a great question. At this point, we actually don't know what is the ideal post-ortho-K corneal shape that serves the most effective anti-myopia dosage. What I'm looking at is I want the central area to have some significant asymmetry. Sorry, not asymmetry, asphericity, meaning only the very center part of the cornea is being flattened the most, and beyond that, I want to see some under correction. So even within this treatment area, we're getting a lot of a positive spherical aberration. And also in terms of the paracentral steepening, there are actually at least 3 components at play. Number one is how much the amount of paracentral steepening we're seeing, whether this is like a 2 diopter, 4 diopter, 8 diopter. Number 2 is the width of this paracentral steepening. So currently, we don't know a narrower but more dramatic paracentral steepening works better than like a wider but less dramatic paracentral steepening. And the third component is related to the size of the treatment zone, which is the location of the paracentral steepening. So the eccentricity, the width, and the magnitude, all of the three are, at least in animal studies, playing a role in terms of the overall anti-myopia efficacy. Currently, we don't actually know what's the best combination. But I do want to say that striving to achieve a smaller treatment zone at a significant cost of losing visual performance, especially like an dawn and dusk or like a nighttime glare, is probably not fully supported based on the evidence we have so far.
Thank you. And kind of following into this anti-myopia theory, another question you brought up, combination treatment therapies. What atropine concentration would you recommend with versus without ortho-K treatment for optimal myopia management?
Currently, for the studies available, they have all been combined with a 0.01% atropine. I would say for combination treatment, before we have further understanding whether it also follows a dose-dependent relationship, I would probably stay on the lower side, meaning 0.01 and 0.02. The reason for that is because due to the pupil dilating effect of atropine, we tend to see more dramatic side effects from ortho-K with the same patient. So you probably do not want to create too much of a compromise on the sharpness of vision with a higher concentration. So my current practice is to stay with either 0.01 or 0.02.
And how about when not in combination with orthokeratology?
So atropine as a standalone therapy does show pretty significant dose-dependent relationship. And so from both the ATOM studies and the LAMP studies, it basically suggested to have a good balance between the tolerability or the severity of the side effects and the long-term anti-myopia efficacy. The range from 0.02, 0.05, or even slightly higher, it sounds like as a more viable option comparing to the 0.01. But I do have to say, at least in our clinic, once we have reached a 0.05 concentration, most of the patients had some level of light sensitivity, and at least my patients, at least around 30% to 40% of them would actually need a different prescription for reading. So the higher we go with the concentration, the more pre-treatment communication we need to deliver to both patients and parents. And so to prepare them, to expect some level of side effects, and also the closer the monitoring frequency.
Yeah, setting expectations with both the patient and parents is so important. And that actually brings up a good question as well with the 5mm optic zone diameter size. Did your patients in the clinical study notice an increase in glare, or would you be concerned about glare and halos increasing in patients in this design?
That's a great question. As I mentioned, most of my subjects are blinded. I didn't tell them which lens they were wearing in each eye, but I did ask them between the two lenses, do they notice more glare and halo in one design versus the other? And subjectively, surprisingly, most of my subjects reported better vision or less halo and glare with the 5mm OZ. And the reason I brought up this topographical slides is to show you, if you had a pseudo-central island, the impact of vision and the impact on glare and halo is probably more than a small reduction in the treatment zone size. So if you're able to flatten the cornea more thoroughly in the center, that actually gets rid of the higher order aberration more effectively than actually increasing the overall size of the treatment area, but having a lot of unevenness in the center. So to answer this question, no, I do not see an increased glare and halo with the 5mm lens.
Great. And that's probably also if we think of how HOAs affect or higher order aberrations affect our pediatric patient population versus our adult patient population. Would you think of this as a lens more targeting the pediatric patient population than adults, or you think it could be equally successful?
I probably will not select my patients based on their age. Overall, I think I'm willing to start with a standard 6mm OZ, whether it's a child or adult patient. But again, currently, we definitely need more studies to confirm or to expand the advantage of the 5mm OZ. Again, as I said, my top two indications, number one is for existing CRT patients, if I see a subtle pseudocentral island, I probably would, my go-to problem solving would be a smaller OZ. And the second is if I'm seeing an isometropic patient, I will probably use two different OZs for two eyes. And third, if I'm fitting a smaller cornea, I will definitely use a 5mm OZ.
Excellent, thank you. And another question in terms of fitting the 5mm design, because the extra 1mm that was essentially taken away from the width of the optic zone and was then redistributed to the landing zone angle zone of the lens, do you change how you fit the landing zone because you're utilizing a 5mm OZD?
This is such a great question. It shows that this doctor probably used a lot of CRT lenses. So my initial lens selection, I will not change the landing zone angle. But if I see the patient presented with excessive edge lift or insufficient edge lift, I do actually take into consideration that each degree of landing zone angle change will cause a slightly different change in the overall sag of the lens. Due to a wider distribution on the landing zone area. So for 5mm OZ in the same diameter, a per degree change in the landing zone angle is likely inducing a more significant change on the overall sag of the lens. And so I do want to make sure I'm changing it correctly. But for the initial either diagnostic lens or the first empirical lens I'm ordering, I tend to use the same LZA as the 6mm OZ.
Great, thank you. Probably one of the last questions of the evening, what was your experience with comfort in the 5mm versus 6mm lens design? Did your patients in the clinical study have any preference?
Not for between the 5 and 6, but their second pair is almost always more comfortable than the first pair. So that shows the importance of lens adaptation. It's probably playing a bigger role than the subtle difference between the 5 and the 6 OZ.
And another practitioner is actually looking at the slide you have up now, and they have a question about the images, the fourth image in both rows. They're wondering why this image looks completely different from the others.
So this patient or this subject, number one, she had a flat cornea to start with. And so I try to use a normalized color scales. Each vertical pair is using exactly the same color scale, but across the board, they're probably using different color scales. So the reason she didn't have that hot ring was because her lower prescription and a flat cornea. So her paracentral steepening is not as dramatic as compared to the other subjects. And the reason that paracentral steepening is not perfectly round was because she actually worn the lenses to school for the follow-up. And so the fitting of the lens in her waking eye and sitting up position was very, very different than her closed eye condition, hence creating a little bit of a secondary molding in her several hours of waking up wearing the lenses.
Thank you. Yes, it's great to see this from a clinical study perspective, because I think if we were to see these results in clinic, we would, somewhat panic and think we need to troubleshoot this lens. But Every cornea reacts differently to orthokeratology lenses, and understanding that corneal anatomy and morphology is also a very large area of interest in the research field.
Exactly.
So I think that concludes our questions for this evening, unless we have any others that are coming in. It seems like somebody just wants to confirm that the advantage of the 5mm lens design is that it's a faster treatment and more paracentral steepening, although it's difficult to actually measure that magnitude. Is that accurate?
Correct, based on this really small study. So I'm hoping to learn better with the actual application of these lenses in the real, like a clinical population.
Great. Well, thank you so much, Dr. Liu, for your time this evening. We really, really appreciate you walking us through your clinical trial and all of the research that you're contributing to the field of myopia management. To all the class attendees, we hope this webinar was a fantastic opportunity to learn why more and more ortho-K practitioners globally are learning about the benefits of decreased back optic zone diameter. Enhance your practice to the next level. Visit our website to become CRT certified and check out our new CRT calculator to make diagnostic fitting a great practice experience. Thank you.